So this discussion is going to focus on the biomechanics of the ankle and foot. So as we're looking at the ankle and foot, you have to keep in mind we're dealing with a bunch of different joints and a lot of different dynamics. Again, particularly looking at closed chain versus open chain activity, because now obviously with the lower extremity, as we've discussed with some of the other joints in the lower extremity, there becomes a much greater impact given standing and walking with biomechanics in the closed chain. So again, we got to look at all the anatomy and all of the kind of relevant orientation of the anatomy whenever we're looking at any of these regions. So I'm looking at the lower leg. We look at the tibia. So the tibia is laterally rotated in the transverse plane. So when you look at the position of the tibia, which is the primary weight-bearing bone in the lower leg, you're going to have that slight bit of lateral rotation. And what this is going to do is put the foot in a more lateral position in relationship to the frontal plane. So naturally the foot is going to be in a little bit more of a lateral position, and it's going to put the medial malleolus in a more anterior position. So when you look at someone in static stance with normal posture, that medial malleolus is going to be a little bit more facing in an anterior direction. We look at the fibula. So the primary responsibility of the fibula is for muscle and ligament attachment. So it only bears, if it does even bear this much, it only bears approximately about 10% of the body weight. So the tibia is the primary weight-bearing bone in the lower leg. And we look at the lateral malleolus, just kind of, again, we look at the orientation. The lateral malleolus projects more distally than the medial malleolus. So the medial malleolus is a landmark on the tibia. The lateral malleolus is obviously on the fibula. And the lateral malleolus is a lot bigger and, again, has a little bit more of a distal projection. And what that does is it makes the lateral ankle more stable. And we'll talk about the dynamics as far as what that means, as far as like the injuries that a lot of times we see in the ankle and how and why one form of ankle injury is more common than the other. So looking at the foot, we have three different portions of the foot. We have the rear foot, which basically consists of the talus and the calcaneus. So again, make sure you're aware of where all your bones are in all of these different regions. But in the rear foot, we have the talus and calcaneus. In the midfoot, we have the other 5 tarsal bones. And then in the forefoot, we have the metatarsals and obviously the phalanx bones and the toes. We also have the arches. So we have the medial longitudinal, the lateral longitudinal, and the transverse arch. And we're going to talk about anatomically what these arches mean and what bones in the foot kind of comprise all of these various arches. So when we look at the motions of the foot and the ankle, it's important to note that they're going to be slightly off from the traditional planes when they actually take place because of, and again, some of this has to do with the orientation of the bones in the ankle. So as you can see in the picture, they're off from the traditional planes, but we're going to discuss them from the standpoint of actually them working within the plane. So we have plantar flexion and dorsiflexion. So it's important to note that plantar flexion and dorsiflexion are motions that take place at the ankle. So at the ankle joint, you only have those two motions taking place, plantar flexion and dorsiflexion, and they're going to take place in the sagittal plane. Inversion and eversion actually don't take place at the actual ankle joint. They take place at the subtalar joint. So a lot of times when we discuss the ankle, we kind of discuss more the ankle complex, not so much the individual joint. So the ankle joint itself, the only motions that take place are plantar flexion, dorsiflexion. Inversion and eversion, which are your frontal plane motions, takes place at the subtalar joint. Now, the other thing that we also have taking place, we don't have a picture of it up here, but it works. It's a motion that the ankle and foot can do. We have forefoot abduction and forefoot adduction, and those are your transverse plane motions. And we'll talk about the significance of them as far as what goes on with walking and why they're important. So when we look at the motions of the foot and ankle, so we talk a lot about combined motions. So the idea of pronation and supination, we discuss this a lot as it relates to the walking gait, because these what we call these triplanar motions. So these triplanar motions, or these combination of motions that we discuss, are very important, because for functional purposes of the ankle, which we'll be discussing, and how the foot operates when we're in our walking gait, these motions become very important. And we're going to discuss these from two perspectives. The perspective we're looking at right now is in the open chain. So the triplanar motions of pronation and supination in the open chain, because this is going to change, and you have to make note of this. This is going to change when we discuss it in the closed chain. So open chain pronation, and the figure demonstrates this with the arrows, is a combination of eversion, abduction, and dorsiflexion. Okay, again, open chain pronation is eversion, foot abduction, and dorsiflexion. Open chain supination is a combination of inversion, adduction, and plantar flexion. Okay, and you can kind of see the foot going in its respective directions. Now, this is going to change a little bit. The motions and the relationship of the joints is going to change when we discuss those in the closed chain, but it's important to note what motions comprise of each one when we're talking about both open and closed chain activity. So some other joints we have to look at is in the lower leg, the tibiofibular joint. So we have two different tibiofibular joints. We have a proximal and a distal, and they're actually both different types of joints. When we look at the proximal tibiofibular joint, which is right here, we see that it is actually a synovial joint. So the proximal tibiofibular joint is a synovial joint. You actually have a joint space, you have a joint cavity, okay? And then when we look at the distal, it's actually a fibrous joint. So the distal tibiofibular joint is a fibrous joint. The proximal is a synovial joint. And again, there's going to be motion that actually takes place. Now, obviously, at a fibrous joint, the motion's a little bit more limited, but the fibula is going to move as we look at movement and motions taking place at the ankle joint. Okay. As far as the kinematics is concerned, we do have some soft tissue restraints that kind of limit the mobility at the tibiofibular joints. So in particular, when we look at the proximal tibiofibular joint, we have motion restraint coming from the various soft tissue structures around there. So even though it is the proximal is a synovial joint, there is some motion restriction because there's a lot of soft tissue that supports that. Specifically, you have the biceps femoris, which is going to insert there. You have the LCL. You have the tendon of the popliteus. You have and then various other ligaments and fascial restraints in and around that proximal tibiofibular joint. So as I said too, the fibula, or these joints, is going to move with plantar flexion and dorsiflexion. So when you dorsiflex the ankle, the superior tibiofibular joint, or the proximal, is going to move superiorly, so it's going to move upwards, and the inferior region, or the distal, is going to abduct and medially rotate. So when you dorsiflex your ankle, again, you can that proximal tibiofibular joint, or your fibular head, is going to move superior, and then the inferior portion of it is going to abduct and medially rotate. With plantar flexion, it's going to be the opposite. So when you plantar flex the ankle, the superior is going to move inferiorly, and the inferior is going to adduct and laterally rotate. Okay, and that motion is very important for functional movement at the ankle joint. And when we look at the end feels, both of them are going to be firm. And again, we're referencing the proximal tibiofibular motion when we're referencing the firm end feel. So again, you can kind of take the head of your fibula. You can actually manipulate the head of your fibula if you feel it along the side of your leg now. If you go up, just watch when you kind of pinch behind it because the peroneal nerve is back there. But if you take the head of your fibula, you can kind of just shift it anteriorly and posteriorly slightly when you do that. Now, we always talk about, again, different types of, anatomical anomalies as far as things that people have. So when we look at the what's called tibial torsion, and this is why when you see the toes, we talked about femoral anteversion and retroversion, but when you kind of see that toeing in and toeing out, you have to determine whether it's coming from a little more proximally up at the hip or if it's actually happening at the lower leg with tibial torsion. So normal tibial torsion, you're going to have a little bit, because remember, your feet just don't come straight forward. They are a little laterally rotated, is about 20 to 30 degrees. Okay, so there's about 20 to 30 degrees of normal kind of tibial lateral orientation. If you have less than that, you have what's called tibial internal tibial torsion, or if you have more than 23 degrees, you have what's called an external tibial torsion. Okay, and obviously, again, this could impact things. Obviously, this could cause a lot, if you think about this, this could cause a lot of problems up at the knee from just walking if you have this abnormal motion in either direction. So, but again, the key with this is clinically. So, for instance, when I do an assessment of somebody and I see, if I just kind of look at even before measuring for any of this, that someone's toes are kind of pointing inward or they just have kind of an extreme lateral orientation in their foot, I have to determine whether it's coming from up at their hip, again, with a femoral anteversion or retroversion, as we discussed with the hip, or if it's an issue with their with the tibial torsion. So continuing to look at the tibiofibular joint. So again, we have arthrokinematics that take place there. So if we look at the and we're really here just looking at the proximal, because again, the distal is going to be a fibrous joint. Obviously, that could be impacted with different types of injuries and issues. If you've heard of the high ankle sprain, that impacts the distal tibiofibular joint. And it could actually, if it's really bad, it could go up into the lower leg and cause damage to the syndesmosis, which is the soft tissue that holds the tibia and fibula together. So looking at the arthrokinematics of the proximal tibiofibular joint, because this is something that you can mobilize and may need to work with in somebody even with a lateral ankle sprain. You have the fibula, which is concave. Okay, so the roll and slide is going to go in the same direction. So the concave fibula articulating with the convex portion of the tibia. So the roll and slide are going to be in the same direction. The resting position or the open pack position of the proximal tibiofibular joint is about 10 degrees of plantar flexion. The closed pack position is going to be full dorsiflexion of the ankle. So the positioning of the ankle is going to be what impacts whether you're in the closed and open pack position. Again, this is something that you can feel for yourself. If you kind of let your foot rest in a little bit of plantar flexion, and you take the fibular head, you can move it back and forth pretty easily for the most part. If you go and dorsiflex your ankle, that then becomes a little bit tighter, you can't move it quite as much. And that's because then it's going to approximate a little bit more. The fibular head is going to be more approximated with the tibia. So looking at the talocrural joint or our ankle joint. So again, we're looking at the actual ankle joint. So you have to separate the ankle joint from the subtalar joint. So the joint classification of the ankle joint is a hinge joint with 1 degree freedom of motion. Remember, we're only looking at dorsiflexion and plantar flexion up at the actual ankle joint. So you have the medial ligament complex, which is very strong. It's also known as the deltoid ligament, if you remember from functional anatomy. So you basically have 4 ligaments that make up that medial ligament complex, and it's much thicker and stronger than the lateral ligament complex. And the reason for that is if you look medially at the ankle, the medial malleolus is not as big and does not project as far distally as the lateral malleolus. So here you're seeing the lateral ankle here, and you're seeing damaged ligaments, and we'll talk about that in a second. But the fibula, the distal fibula, the lateral malleolus, is much bigger and projects much more laterally than the medial malleolus does. The medial malleolus is much smaller, and so you require a lot more soft tissue there to kind of support that. So the medial ligament complex is much thicker and stronger. Now, what I'm showing here is, one of the more common, or actually one of the most common injuries, period, is a lateral ankle sprain. So the reason why lateral ankle sprains are more common is that the ankle has a tendency to move inwards because of the fact the medial malleolus is not as big. The orientation of the lateral malleolus prevents more of the eversion mechanism that would happen with a medial ligament sprain or an eversion ankle sprain. Now, eversion ankle sprains still do happen. They are much more debilitating than lateral ligament injuries because of the fact that the soft tissue there provides pretty much all of the stabilization to the medial ankle. So if you damage that medial ligament complex, your ankle is much more unstable than it is when you have a lateral ankle sprain. And you can see the anterior talofibular ligament, the calcaneal fibular ligament, and the posterior talofibular ligament here, which makes up that lateral ligament complex. So while even if you get damage to more than one ligament, the distal projection of the lateral malleolus provides for much greater stability than you would have in the medial ligament if you damage the medial ligament complex. So still looking at the talochoral joint, and again, you're looking at these pictures, you could kind of see, again, when we're discussing the kinematics, because of the orientation of the medial and lateral malleolus. And again, these are important details to kind of know and understand so that you could kind of see why the ankle moves the way it does. Again, when we're talking about, while we are going to discuss these motions occurring in the planes, they're not as classic as you would get with a lot of the other motions, and that's just because of the orientation of the malleoli. So if you look at the actual planes in the picture, and they're showing it based on the axis. Obviously, we know the corresponding axis that goes with the plane. So in other words, dorsiflexion, plantar flexion, here's your medial lateral axis because they both occur in the sagittal plane. So they're showing you here what the actual medial lateral axis looks like. The red is actually representing where it actually occurs. So you can see there's a slight kind of oblique angle that it takes in real life because of the way, if you look here at the medial and lateral malleolus. So this kind of also harkens back to what I just discussed as to why inversion sprains happen more commonly than medial sprains. Here's the medial malleolus, here's the lateral malleolus. So you can see that, and again, you can see the orientation of the axis here. But again, we're still going to discuss plantar flexion and dorsiflexion occurring in the sagittal plane. Normal dorsiflexion range of motion is about 0 to 30 degrees, from 0 to 30 degrees. So about 30 degrees of dorsiflexion and about 50 degrees of normal plantar flexion. Now, interestingly enough, in order to go through the full motion, both of those are going to require other movements. Okay, so to really kind of plantar flex your foot all the way, there's going to be other movements that take place. The same thing with dorsiflexion. So there's a lot of relationship to the other joints and the movements that occur there. Both of the end feels are both going to be firm for both dorsiflexion and plantar flexion. So they're going to be firm owing to the soft tissue stretch. So when you dorsiflex the ankle, the soft tissue stretch from the gastrocsoleus complex and the Achilles tendon. And then with plantar flexion, you obviously have the anterior tendons and some of the other fascial restrictions that you have on the anterior surface of the ankle joint. So here we get into the arthrokinematics of the ankle joint. So when we look at the ankle joint, you have in the open chain, you have the convex moving on the concave. So the convex talus is moving on the concave tibia, okay, and the kind of the roof of the ankle joint. So you see the roll and slide going in opposite directions. So with dorsiflexion, we're looking at dorsiflexion here. You have an anterior roll and a posterior slide. With plantar flexion, you have an anterior slide and a posterior roll. Okay, and you can kind of see that. The picture kind of demonstrates that really well. So again, here's your dorsiflexion. You're going to get an anterior roll. So again, think of rolling as a continuous thing. So as it's rolling, if it was to keep rolling, kind of keep coming forward. Posterior slide. Same thing here. Now we have a posterior roll. So again, if it was rolling, it would just keep going like this with an anterior slide. The closed pack position for the ankle joint is going to be full dorsiflexion. You know, in athletic training, for instance, when we tape an ankle, we tape it in the dorsiflex position because that's the most stable position of the ankle. Because you know, typically if you're taping somebody, it's because of obviously an injury or they have some type of instability at their ankle. So we want to have it be in that full closed pack position of dorsiflexion. Open pack is at least 10 degrees of plantar flexion. So once you get into about 10 degrees of plantar flexion, you start to get a little bit more of an opening of the talocrural joint. So next we're going to talk about the subtalar joint. And so we're looking at the articulation between the talus and the calcaneus. Now, in kind of looking at this, it's important to note the calcaneal facet. So we're looking at the calcaneus here. Okay, so just to kind of orientate yourself, we're looking at the calcaneus. All right, and it's important to note the different facets. So here's the posterior calcaneal facet, the anterior, and the medial. Okay, so we're kind of looking at a superior view of the calcaneus. And so the talus would be articulating right in here with the calcaneus. So this would be your heel, if you will, when you're looking at the calcaneus. Now, it's important to note that the posterior calcaneal facet is convex relative to the articulation with the talus, whereas the anterior and medial are concave. Now, that's going to become really important when we start to discuss the roll and slide relationship. So make note of that. So again, the posterior is convex. It's a convex surface. The other two surfaces are concave when we're looking at that. And the orientation of what you're going to see with the calcaneus is going to help prevent displacement of the talus on the calcaneus. So that kind of helps to reinforce the stability. And then when we look at the sinus tarsi, so the sinus tarsi is that depression that's right in front of your lateral malleolus. So if you go down onto your ankle, you could feel this for yourself, just come slightly anterior, and that's really where we have some other important ligaments that help to bind the talus to the calcaneus. So you can actually palpate the ATF, which is an ankle joint ligament in there, off of the fibula. But if you go down a little bit further, deeper into the sinus tarsi, you have the interosseous talocalcaneal and the cervical ligament. And these are both ligaments that help bind the talus to the calcaneus and further support that subtalar joint. Okay, so that's an important anatomical landmark and important structures. And again, we commonly talk a lot about, again, with ankle sprains, and again, going back up to the ankle joint, damage to the anterior talofibular ligament, which is the first ligament that usually gets damaged and the most common one that gets sprained in the ankle joint. But these other ligaments in the subtalar joint, you can also get some damage to them too as well. So you have to kind of be mindful of that and any instability that would occur at the subtalar joint. So movement at the subtalar joint, again, is going to be your inversion and eversion in the frontal plane. So obviously we're looking at an anterior-posterior axis. However, again, the anterior-posterior axis is going to be, again, a little off from the classic axis that we look at, again, because of the orientation of the tibia and fibula. So with inversion, we're going to get approximately 30 degrees, eversion about 20, so a little bit more inversion than eversion, again, which would make sense given the fact of the anatomy of the fibula, the lateral malleolus as opposed to the medial malleolus. So this is a uniaxial joint. It's also, again, it's difficult to completely isolate movement. So again, if you go and really try to do full inversion with your subtalar joint, you're going to get other motions taking place at the foot and ankle, and the same thing with eversion. So really, when you're doing that full motion, you're really bringing in other movements that are going to be taking place. So the arthrokinematics, as far as the roll and slide, now remember what we said, the largest facet, okay, which is the posterior, is going to be a convex surface. So you're going to have your convex moving on the concave in the open chain, which means the roll and the slide are going to go in opposite directions. So when the calcaneus moves, you're going to get the opposite motion occurring with the roll and slide. Okay, so if we're looking right here, we see that the person here producing eversion. Okay, so with eversion, you're going to get a, let me pull up my pointer here. With eversion, you're going to be getting a lateral roll and a medial slide. So now you are going to have medial and lateral taking place because we're looking at a straight frontal plane motion with the orientation of the with the subtalar joint. So you're getting a lateral roll and a medial slide when you're performing eversion. If you were performing inversion, so we're looking at the posterior aspect of a right ankle and foot. Okay, if you were to do inversion, your roll would be medial, your glide would be lateral. Okay, so the roll and slide is going to go in the opposite direction. Again, the reason being is because the posterior facet, which is the largest one, is going to be a convex surface. Okay, remember I pointed that out when I was discussing the 3 calcaneal facets in relationship to the talus. So that takes us to the transverse tarsal joint. So we're kind of moving down now more into the foot, and we're going to talk about the transverse tarsal joint. So there's going to be 2 joints that make up the transverse tarsal joint. Okay, so again, you have to go back to your foot anatomy and be thinking about the different tarsal bones and kind of how they articulate with one another. You have the talonavicular joint, which, if you look at the talonavicular joint, it actually very much resembles a ball and socket joint. Okay, so it doesn't operate the way a classic ball and socket joint works with the range of motion, but it does resemble and has the structure of a ball and socket joint. So, and what you have, one of the important ligaments or structures that you're going to have is going to come from what's called the spring ligament, also known as the plantar calcaneonavicular ligament. So the spring ligament is actually going to support and maintain the talar head and maintain the medial longitudinal arch. So that spring ligament is going to be important to kind of supporting this joint and supporting this region. Then you have the calcaneocuboid joint, which is a modified saddle joint. The primary support for this joint is actually going to come from the long plantar ligament in the foot. So the long plantar ligament in the foot is going to support and maintain the stability of this joint when we're looking at the transverse tarsal joint. So the kinematics, again, this joint is really going to influence the longitudinal arch, okay? And the rotation at this joint is actually going to occur around 2 axes, and we'll kind of show this on the next slide, how this is actually going to occur, and we're actually going to refer to these axes differently than what we've actually done in the past, because these kind of take on a much different orientation, even more so than when we were looking at plantar flexion, dorsiflexion, and inversion and eversion. Okay, so we'll talk about the rotation around the 2 axes. It's important to note that most of the motion at this joint is going to come from the talonavicular ligament. Okay, so the calcaneocuboid is going to contribute to motion, but the talonavicular ligament, and again, even if you just think of, again, we said that the talonavicular ligament is essentially a ball and socket joint because of the way the talus kind of fits into the navicular. There's more motion that takes place there. And what we're essentially looking at here is movement of the forefoot on the hind foot. Okay, so we broke up the forefoot and the hind foot as we were kind of going through this. Okay, so the motions that take place here are inversion and eversion. So inversion and eversion takes place at the transverse tarsal joint. And you have the combined motions of dorsiflexion with foot abduction and plantar flexion with foot adduction. Okay, so again, inversion and eversion, and then you have your combined motions of dorsiflexion with forefoot abduction and plantar flexion with forefoot adduction. And what this joint in conjunction with the others does is helps to create that triplanar motion that we discussed previously of pronation and supination. This joint also helps to elevate your arch when you supinate and depress it when you pronate. Okay, so this, again, we talked about how this controls the arches. When you supinate your arch in the closed chain, your arch elevates. When you pronate your foot, your arch depresses. Okay, and we'll discuss that further when we kind of get into talking about why that's relevant when you walk, why you need to supinate versus pronate. So we mentioned how it rotates along two axes because there's actually two joints when we're discussing the transverse tarsal joint. Again, most of the motion, or the motion primarily takes place through the talonavicular joint. So in looking at these pictures, and again, and I guess I should have said this earlier, again, you may want to take pauses at certain points to orientate yourself to these pictures. So stop the video, take a look at and orientate yourself to what you're looking at as you're taking notes. Okay, so as I said in the beginning of this class, it should be rare that you just play one of these videos straight through. You should be pausing, you should be, making note, orientating yourself to pictures and structures, whether it's through the pictures and structures that I show on here, or whether it's maybe even going back to your textbook and looking at some illustrations so that you just understand this. So here we're looking at adduction and abduction in these pictures here, and here they're orientating you to dorsiflexion and plantar flexion. Now, in this picture, the red is kind of the actual axis that the movement takes place on, and the black line is going to be your kind of classic axis that you look at. So the actions of inversion and eversion that we talked about with this joint takes place along what's called a longitudinal axis. Okay, so again, we're talking here the transverse tarsal joint. We're not talking about the subtalar joint. So the transverse tarsal joint, inversion and eversion, are going to take place along a longitudinal axis. The combined actions of dorsiflexion and abduction and plantar flexion and adduction take place along what's called an oblique axis. Okay, and the reason for that is, again, orientation of the foot. So this is a situation where we're going to kind of be calling the axes by different names. Okay, again, the longitudinal axis, inversion and eversion, the oblique, the combo motions of dorsiflexion and abduction, and plantar flexion and adduction. So, and again, what that's going to do is, so the transverse tarsal joint coupled with the other joints is going to help to promote that supination and pronation, or that triplanar motion that we discussed earlier. Now, as far as the range of motion, just all I want you to know is that, and this is referencing the triplanar motions, there's much more supination than there is pronation. So the overall measurement of supination is going to be greater than pronation. There's more range of motion in that particular direction. So we look at a functional aspect of the transverse tarsal joint. So the whole, again, the whole with this combined with your other motions is going to contribute to the idea of pronation and supination, which is going to be a big thing when we start to look at what goes on when we walk. So at the transverse tarsal joint, so this picture is showing you the transverse tarsal joint when the kind of ankle complex is pronated versus when it's supinated. And this is an important thing. So the axes of motion are parallel when the ankle and foot is in a pronated position, and they're kind of crossed when it's supinated. Now, the relevance of this is that when your ankle joint, the subtalar joint, the ankle joint complex is in a pronated orientation, the transverse tarsal joint becomes more hypermobile. So in other words, there's more movement, because you're looking at the transverse tarsal joint here. There's more movement that can take place when the joint is pronated. When the ankle complex is supinated, it locks. The relevance of that is when you're walking, you need pronation to occur in order to allow the foot to adapt to the surface that you're walking on. Okay? So when you're through your walking gait, you have pronation that takes place. That's to allow your foot to adapt. When your ankle and foot supinates, you need it to be locked and you need it to be stable because you're using it to either absorb force or to produce force. And in both instances, that joint needs to be locked. So this creates a much more stable position for the transverse tarsal joint, whereas over here, it allows it to be a little bit more mobile and allows it to adapt to the different surfaces that you're walking on. So looking at the transverse tarsal joint, looking at the arthrokinematics, we're going to look at these as two separate joints. Now, I'm going to caution you on this, and this was, I think, an oversight in the book. So in this picture up here, they're showing the transverse tarsal joint here. It's actually a mistake. It should be back here, because this is your talonavicular joint right in here. They're still showing the arthrokinematics correctly, but for some reason they highlight it. The joint here, it should really be back here. This is your talus, this is your navicular, so that would be the talonavicular joint. So, however, the arthrokinematics, they are showing correctly. So the roll and slide are going to go in the same direction. You can kind of see here a little bit where I was talking about how the talonavicular joint looks like a ball and socket joint. So it essentially is a ball and socket joint. You kind of see the convex talus and the concave navicular here. Okay, you can kind of see the navicular kind of accepting that convex shape there. So the roll and slide are going to go in the same direction. When we look over here, you have the calcaneo-cuboid joint, which they're showing correctly here. Now, the calcaneo-cuboid joint is a saddle joint. There's actually convex and concave surfaces on both ends of that. So when we're looking at the motions that take place here, so for dorsiflexion and plantar flexion, the motions are the same at both, okay? With abduction and adduction, the calcaneo-cuboid is having the convex moving on the concave. So that's an important point to know. As far as the open packed position and the closed packed position at these joints, again, it's going to be the same for both. The open pack is midway between the extremes of all the motion for pronation and supination. The closed pack is going to be full supination. And again, if you think about what we just discussed, again, supination is where the foot becomes more rigid for push off and to absorb shock. So that's going to be where the closed pack position is in full supination. All right, moving on. So now we're moving further down the foot. We're looking at the tarso-metatarsal joints. So again, this is where the tarsal bones meet up with the metatarsals. This basically helps to form the transverse metatarsal arch. It also helps to contribute to the longitudinal arch. And again, this is kind of the link between the rear foot and the forefoot. Okay, so we have the rear foot, midfoot, forefoot. Well, this area is kind of that link between the two. So, and essentially what you have are the metatarsals articulating with the cuboid and the three cuneiforms, and that's going to form what's called the Lisfranc joint, which is where the metatarsals and the tarsal bones come together. Now, as we're looking at this articulation, there's actually separate sections to it. So the first metatarsal has its own joint capsule with the corresponding tarsal bone. So again, look at the metatarsals and how they articulate with the tarsal bones. So the first is the largest and has its own joint capsule. The second and third each have their own joint capsule, and then the fourth and fifth kind of come together, and that's the most mobile of the sections. So the fourth and the fifth, if you kind of look at how they articulate with the cuboid. So basically, when you look at your cuneiforms, the first cuneiform articulates with the first metatarsal, the second with the second, and the third with the third, and then the fourth and fifth metatarsals articulate with the cuboid. And that's the most mobile of this entire joint as far as the actual sections of it are concerned. Then we have also, you'll hear the term, they talk about the rays. So the rays are functional units of the forefoot. So the three medial rays include the metatarsal and the corresponding cuneiform. So in other words, the first ray is the medial cuneiform with the first metatarsal. The second ray is the middle cuneiform or the second cuneiform with the second metatarsal, so on and so forth. The fourth and the fifth rays are just the metatarsals. So this goes again from in the case of the first ray, the medial cuneiform, the first ray all the way up through the toes, and then going along, and then the fourth and the fifth, they don't have a corresponding tarsal bone. It's just the fourth and fifth metatarsal with the individual toes. And each one of these joints is a plain synovial joint. So that's what we're going to be doing. So we're pretty much just looking at gliding motions taking place between these individual joints. The intermetatarsal joint, so now we're looking at the articulations between the metatarsal bones. So all the metatarsals rotate around the second. So the second kind of acts as the base, is kind of the least mobile. The ligaments in this joint are responsible to help limit the splaying of the metatarsal heads. So obviously the metatarsals have to be able to adapt to the ground and everything when you're walking, but you don't just want them completely kind of splaying out and having all the arches completely go flat, because that's not going to allow the foot to have any stability. So the ligaments present throughout here are going to help to limit that. And again, you have your synovial joints between the second and third and fourth and fifth. So the first the first and the second kind of act a little more independently when they're actually working between each other, but between the second and third and fourth and fifth, you have synovial joints. So now moving further down the foot, we're looking at the metatarsophalangeal and interphalangeal joints. Now it's important to note that the metatarsophalangeal and interphalangeal joints structurally are very similar to the metacarpophalangeal and interphalangeal joints in the hand. Now structurally they're very similar, but they have to operate very differently because of what the foot does in walking. That's going to impact what your toes do much differently than with your fingers. So motion's going to occur here in the sagittal and frontal plane. So we're going to look at the metatarsophalangeal joints first. So you obviously have your convex metatarsal heads articulating with the concave proximal phalanx bones in the toes. Okay, so your roll and slide basically are going to occur in the same way. The difference is, and again, that's very structurally similar to what you look at with the hands. The difference is you have much greater hyperextension. If you compare what you do with your fingers versus what your toes have to do extension-wise. So there's actually more extension present in the toes versus flexion. So that's reversed from what you deal with the hands, and the reason for that is you need that with your walking. Okay, when you walk, your toes need to have that hyperextension, particularly at your great toe, in order to have your normal walking gait. So all of these joints are going to be biaxial, flexion, extension, add, and abduction. So you have your sagittal and frontal plane motions. When we look at open and closed packed position, we're going to separate, much like we did with the hand. We're going to do the same thing with the great toe versus the 4 smaller toes. So with the great toe, the closed packed position is hyperextension. For the 4 smaller toes, flexion is the closed packed position. The open packed for all of the toes is going to be slight extension, about 10 degrees. When we break down the great toe versus the 4 smaller toes as far as the MTP. So I'll go through that one more time. Again, the great toe, closed packed, hyperextension. For the 4 smaller toes, it's flexion. And then for all of them, it's going to be the open for all of them is going to be the same. It's slight extension. Now we look at the interphalangeal joints. Again, structure very similar to the fingers. So, and again, much like the fingers at the great toe, for instance, like the thumb, you only have an IP joint. In the 4 lateral smaller toes, you have a PIP and a DIP. The IP joints, the closed and open packed position, are all the same. So the closed is going to be full extension, open is going to be slight flexion. So we've discussed a lot about pronation and supination. So these are going to be motions primarily occurring at the subtalar joint. Now the movement depends on whether you're looking in the open versus closed chain. So we discussed open chain pronation and supination already. So when we're looking at this picture here, just to kind of review. So here's your open chain supination and the motions that coincide with it. So we did all this earlier. And here's open chain pronation with the motions that coincide with it. So if you don't remember what these motions are, go back and review your notes because we already did it. Now what we're going to do is kind of talk about the orientation and what joints are involved when we get into the closed chain, because it's going to change based upon now the fact that your foot is in contact with the ground and what that's going to mean for the bones and joints involved. So now here we look at closed chain, so we could see the foot in contact with the ground. Okay, now if we look over here, this is closed chain supination. Okay, so now the motions associated with closed chain supination, you now have dorsiflexion and foot abduction, and the abduction is going to occur with the talus on the calcaneus. So this is a different orientation versus the open pack, or the open chain rather, position. Okay, you're also going to have inversion at the calcaneus. At the transverse tarsal joint, you're going to have supination. Now you also have tibiofibular involvement here, because now the tibiofibular joint is also going to be involved. The tibiofibular joint is going to laterally rotate, and you're also going to get lateral rotation at the femur. So we're going to see on the next slide how the hip actually now is going to get involved with this motion at the foot and ankle. If we come over here to pronation, now we look at plantar flexion and adduction of the foot, again with the talus on the calcaneus. The transverse tarsal joint will either be pronating or supinating, depending upon which part of the walking gait you're in. The calcaneus is going to evert, and now you're going to get medial rotation of the lower leg. So again, looking at the tibiofibular joint, and also you're going to get medial rotation at the hip. So you have a lot more involved with this kind of going up the kinetic chain. We're going to see and talk about that a little bit more on the next slide. You can see how these two things are, how these different areas are going to interact. Okay, so here we see pictures, and we can start to see what's going to happen at the pelvis, the lower leg, the hip, and this is going to kind of carry into, after this exam, the first topic we're going to be talking about is posture and gait. So a lot of what we talk about in this chapter, and even in the other chapters, it's going to be really important that you know the interaction and the joint motions that are going to occur when we're talking about gait. So we look at the other joints in the ankle and foot. So the transverse tarsal and the tarsal metatarsal joints are all going to be involved. Again, it's important to note that the talonavicular joint is going to produce most of the motion at the transverse tarsal joint. So, and when pronating, the transverse tarsal joint can do either in an effort to keep the toes on the ground. So that's why I said that when an individual pronates, the transverse tarsal joint can actually pronate or supinate just to keep the toes on the ground, because that's going to be what's important for there. Again, we see what goes on with the hip and lower leg. So in this picture here, we're looking at pronation, right? So with pronation, you're getting internal rotation at the lower leg, the tibiofibular joint. You're getting internal rotation at the hip. You can also see what the pelvis is doing in response to that, okay? And you could also see what the knee's doing. So again, what happens down at the foot could also impact the knee and the hip. So if someone has an issue down here at the foot, they could also start to develop both knee and hip problems. Over here, we look at supination. So with supination, you're getting lateral rotation at the lower leg and lateral rotation at the hip. Okay, and then you're also seeing what is going on up at the pelvis. So you can see how this motion kind of goes all the way up through. So now obviously these are motions that have to occur. So these aren't abnormal motions. The problem is when somebody overpronates or oversupinates or does it in areas of the walking gait where they're not supposed to, that's where you're going to get added stress. So it's important to note that there'll be compensations if there's too much of that going on. So all of these motions have to occur for normal walking gait. The issue becomes is when they basically appear in portions of the walking gait where they're not supposed to, or you get hyperpronation, hypersupination, and that's where there's going to be structural issues, foot pain, hip pain, knee pain associated with some of that compensation. So looking at the arches, we've alluded to the arches a little bit throughout our discussion. Again, the functions of the arches is that they allow the foot to adapt, they allow the foot to become rigid for propulsion, and they also allow for good weight bearing and for a base of support. Now the structures involved with the different arches, so we have the medial longitudinal arch. That arch comprises of the calcaneus, the navicular, the medial cuneiform, and the first metatarsal. You have the transverse arch, which you can see just kind of comes across the middle part of the foot. The transverse arch is going to be concave and weight bearing at both, should be concave and weight bearing at both the mid-tarsal and tarsal joint. So if that arch is flat or convex in weight bearing, that means that there's an issue there related to the structure of the foot. Then you have the lateral longitudinal arch, which is comprised of the calcaneus, the cuboid, and the fifth metatarsal. Now, obviously, the lateral longitudinal arch structurally is much different than the medial longitudinal arch. The medial longitudinal arch kind of has a little bit more of a bigger arch, if you will, and is more pronounced than the lateral longitudinal arch. And again, that's going to be for reasons as what the foot has to go through when you're going through the walking gait. So when we look at the arches, the shape and structure, again, they give shape and structure to the foot with weight bearing. So what they actually kind of act like is they act like a curved beam design. So if you look, down here, they're kind of showing structurally what that curved beam design looks like. And what that does is it just allows the foot to accept larger forces. Okay, that's important. So that's part of the reason why people have flat feet, that their body can't accept forces as well. Now, however, if you have a really high arch, there's also compensations that occur as well. So it's kind of that optimal positioning for the foot. So it gives kind of convex and concave shape to the foot and the forces. So when the foot gets loaded, there's different forces taking place. You're going to have compression forces on the top of the foot and tension forces on the bottom. So when you're looking at this strut and tie rod structure, so basically what they're showing here is when the foot comes down, there's going to be compression forces at the top coming down on the foot. What that's going to do is stretch out this bottom part of the foot, which is going to create tension forces. Now, on the bottom of the foot, you have what's called the plantar aponeurosis, which is a tissue structure that supports the ligaments and muscles at the bottom of the foot. So it's basically a fascial structure on the bottom of the foot where that tension kind of gets absorbed, and that helps to support the ligaments and foot muscles. Okay, that plantar aponeurosis is also very important to the integrity of the foot. Again, it kind of helps to maintain its shape as best it can. That plantar aponeurosis actually goes all the way through the bottom of the foot up to the distal metatarsal phalangeal joints. So what that does is when you extend the great toes, it prevents the arches from collapsing. So in other words, that gives your foot some rigidity when you're walking. So if you notice when you extend your toes, that arch becomes more pronounced. And the reason for that is that plantar aponeurosis tensions up, and that helps to keep the arch very supportive when you're walking, and allows your foot to maintain its rigidity when it needs to. Talk a little bit about this. Ties into the windlass mechanism. So the windlass mechanism is responsible for creating a higher arch. Okay, so when you see here the foot in the weight-bearing position, basically when you're getting that plantar flexion at the first ray, this plantar aponeurosis is going to tighten up, which is also going to cause the intrinsic muscles to tighten. That actually makes your arch much higher. So, and the interaction here comes from the contraction of the extrinsic muscles outside of the foot, particularly the gastrocsoleus complex. So you can see this for yourself on somebody. When somebody goes up on their toes, their calcaneus will actually invert a little bit and their arch should get bigger. That's a normal response to going up on your toes. So one of the things in kind of testing people with foot and ankle problems that you have people do is actually view them from behind going up on their toes. The normal response, the normal windlass mechanism, should create slight inversion taking place and the arch getting bigger. If that doesn't happen, that's showing that their foot lacks the ability to maintain that arch and maintain the rigidity that the foot needs as they're going through their walking gait. Okay, kind of coming back to the arches, again, as we showed, both the extrinsic and intrinsic muscles play a role with supporting the arch. So your most prominent extrinsic muscles that are going to play a role with this are the peroneus longus and the tibialis posterior. So those muscles are actually, the tendons from those muscles are actually going to help in supporting the arch, and then obviously you have the intrinsic muscles that are going to support that as well. So the toe muscles don't have a whole lot of function in the open chain. Obviously they can flex and extend the toes, but again, open chain function is not really what we're looking at. We're really looking at is what the toe muscles are going to be doing in the closed chain. And you're going to have your other intrinsic muscles that are going to kind of help to support the arch. So the flexor hallucis longus, the abductor hallucis is going to be very important with kind of supporting that medial portion of the foot. When we look at the lateral longitudinal arch, the abductor digiti minimi is going to be important in supporting the lateral longitudinal arch. Now, it's important to note that people with flat feet are going to have increased activity of the tibialis anterior and posterior when standing, because of the fact that those muscles are going to have to become very active in helping to support the foot when they're weight bearing. Another very common thing to find in people with flat feet is that their feet tend to sweat a lot as well. And part of the reason is because the intrinsic foot muscles have to work, they almost have to basically work overtime in kind of helping to support the foot. So that's another, common question or something, when you're kind of doing a foot and ankle exam, you'll ask, well, do you notice if your feet are sweaty? And many times, again, people with flat feet will report that as well. So just to kind of wrap up some loading in the foot, and again, some of this we kind of talked about earlier. Again, a lot of this information is going to be very important in the carryover to the next section when we talk about posture and gait. So the first metatarsal is going to bear more weight than the lateral four. So overall, your first metatarsal is going to bear more overall weight, which makes sense. It's the biggest of all of the metatarsals. As far as between, when we look at loading throughout the other part of the foot, there's about a 50-50 split between the metatarsal heads and the calcaneus. During walking, the heel and the great toe experience the greatest forces, which if you think about it makes sense. When you bring your foot down at heel strike, your heel's going to bear a lot of force and weight with that. And then when you go into toe off during the walking gait, your great toe is going to have a lot of forces on it at that point. So that's where the greatest forces are going to take place. We talked about what happens to the calcaneus when you raise up on your toes. Again, due to the windlass mechanism, your calcaneus should actually invert slightly. Okay, again, if you don't see that inversion of the calcaneus when you go up on your toes, it shows that there's a deficiency. And actually, typically what that shows, I didn't mention this earlier in talking about this, but usually it means that the person has an insufficiency with their tibialis posterior. So it means that their tibialis posterior isn't as strong as it should be, or that there's dysfunction with that muscle, and that's what's basically creating that abnormality when they go up on their toes. So here's just kind of a picture. So it's always good to tie in some actual practical clinical stuff with this. So you see some common foot deformities that you have. So here is what we call a pes planus, or a flat foot. Now this person here, they have a structural flat foot. So there's two different types of flat-footed people you can have. You can have a functional flat foot or a structural. A structural person just has a flat foot all the time. A functional flat foot, when they're non-weight bearing, they have an arch. When they go weight bearing, they have a flat foot. Now you might be sitting there saying, well, Jason, they're weight bearing, so how can you really tell? Usually when you see this flat of a foot, that means it's a structural flat foot. My guess would be that would be the case with this person. With a functional flat foot, they'll flatten out, but you might still see a little hint of an arch. This person is just completely flat. This is what we call a pes cavus foot. So this is a high arch. So in either case, you're going to have problems. Now, typically what you have with the flat foot is that their foot doesn't get rigid, and it's kind of hypermobile all the time. The person with the pes cavus foot, their foot is rigid and never gets mobile enough to adapt. So there's some different problems that could arise with each one of those. Here you have what's called a hallux valgus, and with that they also have what's called a bunion. So with a hallux valgus, the toe is kind of, the toe isn't straight like it should be. It's kind of pointing off to the side. And then you have, typically what that person ends up developing is a bunion, where it starts with a bursal irritation at the first metatarsal head, and then it kind of calcifies over time, and that obviously becomes very painful for them with walking. And now here, and again, here you have your learning objectives. Now it's important, or your learning outcomes. Well, learning outcomes, learning objectives, same thing. Again, important to note, and I've been talking about this more so in the discussions in class. So again, the lectures, I don't talk about the muscles the way the textbook does. Now, again, you have to know the anatomy to kind of know and understand this stuff. So when you're doing your reading and stuff, don't necessarily just bypass that because of the fact I'm not talking about it in the lecture. The lecture is to highlight the pure biomechanics portions of this, whereas the muscle things at this point should just be reviewed because of the fact that we've had functional anatomy. So please make sure, again, so you have to ask yourself, how well do you really know the foot and ankle muscles? Make sure to review that if you need to, again, in kind of helping to further your understanding with this.